Hello, good evening to all. On behalf of IAP Digital Team, I welcome to all participants, our guest and our resource person. Before hand over this webinar to our today's moderator, Dr. Kaushik sir, I request to all participants, please subscribe our IAP YouTube channel and Facebook page for watching more and more live webinar. Thank you. Hand over to you, sir.
Thank you, ma'am. Good evening, everyone, and very warm welcome to our 12th webinar organized by IIP West Bengal branch. On behalf of IIP West Bengal branch, I do welcome you to all for the webinar of knee injury in sports by Dr. Avishek Das. He is a consultant orthopedic and joint replacement surgeon, presently attached with Columbia Asia Hospital, Salt Lake, Iris Hospital, Bagajotin, Apollo Clinic, Newtown. Let also welcome our organizer, Dr. Riziraj CEC is shown. Dr. Riziraj, please say something.
Good evening, everyone. First, I would like to thanks Dr. Avishek Das sir for conducting this 12th IIP National IIP webinar, state webinar. So I requested all EC member of West Bengal for conducting this knee injuries in sports webinar. I would like to again thanks for Abhishek sir for this webinar.
Now I would like to call our secretary, Dr. Arindam sir. Arindam, please say something.
Welcome, sir. Dr. Das has given time us to share his knowledge and expertise in the knee injuries in the sports cases. I warm welcome, sir, and hope this webinar will give a new light to all the participants in the sports injuries, what will happen in the knee joints. And I wish all the success of this webinar. Thank you.
Dr. Das, over to you. Please share your screen and start the session.
Thank you. First, I would like to thank you all for giving me this opportunity to share my experiences with you all on this lovely evening. I will be having a short presentation. I will try to be as interactive as possible because well, one-way communication becomes boring. So more we have an interaction, more we learn from each other's experience. I will be discussing a few cases, less of theory, a few cases, and a couple of videos of what actually we do in arthroscopy and what happens inside the knee. So after the presentation, I think we will have a short sort of interaction where both of us can, we all can learn from each other and get enriched.
Yes, sir. We have the question and answer session.
Yeah. Okay. Is it visible to all?
Yes, sir.
Yeah. Okay. So knee injury in sports. So the first thing when we talk about sports, the first images that come to our mind is basically either Messi trying to run with the ball, dribbling people, or Saina Nehwal trying to reach the cork for a lovely return, or Virat Kohli trying to make ground before the ball actually hits the stumps. They are all sports icon, and sports has its share of follies as well. Quite often the sports person are plagued by the various injuries, and knee bearing a weight bearing joint and one of the essential joints for mobilization shares a big brunt of injury. It's not that the icons only suffer from the knee injuries. There's a lot more of people around him, the other sports person who participate in various tournaments, they play in their life, and all the people who are supposed to be occasional players, they unfortunately all of them has to bear the brunt of sports injury at some point of time or others. And there it lies the basically our role, your and ours, where when they come to us, they want to get back to their original sports fit and fine as early as possible. So basically we work as a team. We the I, the orthopedic surgeon, and you, the physiotherapist, we have to work as a team to give back their original mobility, agility, so that they can get back to their career and the sports life as early as possible. Before we actually start discussing of the sports injuries, let's start from the very basic anatomy. We all know that the knee joint is primarily consists of two bones, the upper femur, the lower tibia, and we have the meniscus, which acts as a buffer in between the two bones and which actually smooths out the movements between the knee, that is the femorotibial joints. Apart from the meniscus, we have a couple of very important ligaments, the anterior cruciate ligament, which prevents the anterior translation of the femur over the tibia, and the posterior cruciate ligament, which resists the backward movement of the femur over the tibia and gives us a stable knee. The medial and the lateral collateral ligaments on either side of the joints helps to stabilize the knee in their respective positions. So all these ligaments act in a tandem to give us a stable knee and help the sports person to continue their journey and their career. Let's start with something a little innocuous and more often neglected syndrome. I mean, not syndrome, actually more often complaints. You'd see a lot of patients do come in with complaining of pain in the knee, particularly the anterior portion of the knee. It's a this is the pattern of humeral pain, which frequently so just a moment, that frequently involves the athletes. Most of the younger patients or the sports person, they do not have a structural change to the patellofemoral joint or a cartilage damage, but they do complain of patellofemoral pain. The key factor in the patellofemoral pain development is the dynamic valgus of the lower extremity, which leads to the lateral patellar maltracking, and the continuous lateral patellar maltracking whenever the person tries to run or mobilize, they contribute to the patellofemoral pain. In most of the cases where there is no bony deformity such as increased Q angle or a cartilage damage, in those individuals, physiotherapy, rehab, exercise to strengthen the muscles targeting the muscles of the hip, knee, the quadriceps, hamstring, the trunk, and the iliotibial tract are sufficient to build up the muscle strength, and most of the individuals do improve on physio and rehab. Next, we come towards perhaps the most important ligament inside the knee, and the ligament whose injury is most common. That is the anterior cruciate ligament injury. Now, before we start the injury, let us discuss how the injury happens. The anterior cruciate ligament is more prone to injury when there is a sudden change in direction or a pivot against a locked knee. Say the person is running and suddenly needs to change the direction, like playing with the football, suddenly wants to dribble and change the direction, or say a cricketer completes his run up and strives for the second or third run. That is when there's a sudden change and a sudden force on the locked knee, when the individual hears a pop and thereafter feeling of pain, swelling in the knee, and unable to get up or continue the running or the play. Now, if there are various grades of the ACL injury, the first or the most innocuous is the sprain. Sprain is basically uh, it, it's basically an injury to the muscle fibers, and there's not a proper tear, but the muscle fibers get injured and bruised. Invariably, in all these individuals, they do not require a surgery or an orthopedic opinion as such, and most of the rehab done properly are sufficient. Like you start off with the rest, ice compression, elevation, and thereafter start strengthening muscle and rehab, and most of them can get back to their original sports and original pre-injury level when the rehab is complete. But more often what happens is the rehab is neglected, so an inocuous sprain of the ACL can give rise to a long-term debility and less than optimal return to sports. The second is a partial tear, where a part of the anterior cruciate ligament fibers are torn. Anterior cruciate ligament, as we know, have a two bundle. It may be a bundle tear or a part of the bundle which tears. Now, the partial tear in case of a sedentary individual do not require a surgery, but for a sports or an athlete person who wants to get back to the original sports, running and everything, they require some sort of operative intervention. The third comes the complete tear, where all the ligament fibers or most of the ligament fibers are torn. They invariably would require reconstruction either with its own graft or an allograft to get back to their pre-injury level. The last in the list is bony avulsion. Most commonly, there's an avulsion of the bone from the tibia, which gets ripped off from the tibial plateau along with an ACL. So this definitely will need an intervention and fixation to recover the strength and original function. Now, of late, there has been a focus on repair of the ligaments. Now, why repair? Because the repair gives us the advantage of trying to retain the original ligament. It gives a better sense of proprioception and better ligament function in the long term. But it has a higher failure rate. So we should be very meticulous in choosing the individuals who are good candidates for repair and who would not benefit for repair and would require a reconstruction. Now, in selected individuals of partial ACL tear, like when there's a proximal avulsion tear in the femoral part, or there's a good tissue, it's a good idea to go for a ACL repair, because that helps us to retain the original ligament of the individual. So as the concept of repair comes in, so do the concept of internal bracing also is gaining momentum. What happens in internal bracing? Basically, as we see, we use an additive fiber to the repaired ligament. This fiber acts as a reinforces the ligaments and helps to protect the ligament in the early stage of recovery. The advantage of adding an internal bracing is that you start the rehab faster, the patient gets back his mobility faster, and return to pre-injury level is faster. And the chances, it has been seen, the chances of failure of a repair are more in the initial phases. So when we are using an internal bracing, the ligament is protected during the initial stress and strain till the ligament is fully recovered and gets back its original function and strength. This is the first individual who actually had come to me after falling after a twisting injury in the knee while running. So if we see the x-rays, the AP x-rays is not very conclusive, but on the lateral views we see a ligament, a portion of the bony ligament which is actually lifted off from the tibial plateau. So this is actually avulsion, ACL avulsion, where the ACL ligament has ripped off from with a part of the bone from the tibial plateau. So this definitely requires a fixation. Now, if we go into the classification of ACL avulsions, I will just broadly classify into displaced and undisplaced. A truly undisplaced ACL avulsion may not need fixation because it will heal in its own place. But we have to be actually very cautious in trying to identify the truly undisplaced, because as we see in the x-rays, if you see only an AP view, this looks as an undisplaced ACL avulsion. But once we go to the lateral view, we see there's a displacement. So from my side, before I actually commit to a conservative management for an undisplaced, I would like to have a CT scan, so with a 3D image, so that I can be absolutely sure that this is a truly undisplaced ACL avulsion. Then only I will go for conservative management. Any displacement, any hint of instability, I would rather lean or prefer going for a proper reduction and a fixation. Now let's come to the types of fixation. Well, previously there was a fixation they used to do with the cancellous screw or the staples. Both are metal implants. The advantage is basically it's easier to do cancellous or screw the staples, but the problem is you are actually putting in a hardware inside the knee. So number one, the chances of failure are more, because more often the fragments are very flimsy. So if you put a cancellous screw, the purchase may not be good enough. Secondly, and more important thing is it needs an implant removal. After some time, when the fragment unites, more often the cancellous screws of the staples cause an hindrance to the knee movements, and we have to do a second operation to take out the screws of the staples. So now the preferred mode of fixation is using a sutures. So we use a suture breeze. We put a suture from outside. It goes inside, loops around the tendo bony junction and fixes to the bone. I'll just show you a video, a short video where I will actually demonstrate the procedure, what we do and why this is better than the others. So this is the MRI. Again, in the MRI, we can see this is basically the portion of the bony fragment which is lifted off from the tibial plateau. There's a lot of bone edema around here, which shows it's a fresh fracture. So we can see this is a nearly intact ACL. It's only the avulsion of the attachment to the tibia. And here we can see an intact PCL. So this is basically an arthroscopic image because right now the preferred modality of treatment is arthroscopic and not open, as it's less it's less invasive and helps in earlier rehab. So once we go inside the knee, it's quite busy out there. We have to shave off the synovium and everything. And after that, we can see this is basically the ACL ligament, where the attachment to the femoral side is okay. But once we come to the tibial side, we can see a small fragment which is being lifted off from the tibial surface. It's extremely essential that we do a thorough debridement of the surrounding synovium, surrounding tissues, because a clear visibility is of paramount importance, because we have to fix the fragment properly in its position. Any displacement from the original position will alter the ligament length and the tension. So what happens is the ACL will not get back its original strength and function. So that is not desirable. So here we see the bony fragment is basically carefully liberated from the adhesion surrounding the knee, the tibia. We're shaving off the fibrous tissue around which would be interfering in the fixation. This is basically the undersurface of the fragment. And this down, we can see the crater or the region where the bony fragment has ripped off from. So basically this initial part is quite cumbersome and requires a lot of patience in clearing out the structures, because any hurry, any neglect in this part have a long-term debilitating condition reduces the chances of union, increases the chance of failure, and delays the rehab. So once the fragment is liberated from the area, we do a thorough cleaning of the crater. This is basically the crater where we would actually put back the structure. So the junction, the fibrocartilage are being entirely shaven off properly. So this takes some time, and I think it's a good policy to invest some time here. So this is, again, we check the integrity of the ligament because we have to be absolutely certain that there's no other injury to the ligament elsewhere. Otherwise, we go in for a reconstruction instead of trying to fix it back. And also, we need to be careful that the anatomy of the ligament is preserved. It's not a degenerated one. It looks a fairly good ligament. So once it's put back properly in place, the individual will get back to its previous pre-injury level activities. So, and there's the other thing which should be careful, because the fragment is a very flimsy one. Because I will be showing you slightly later, it's not actually a big chunk of bone. It's a very flimsy chunk of bone. So we have to be absolutely very gentle, and have to take time to actually clear off the fragment. Otherwise, what happens more often, we come out and the fragment becomes in bits and pieces, 2-3 fragments, and it becomes almost impossible to fix it back. So the other problem which was there with the screw was, once we tried to put in the screw, this fragment used to become in pieces, 2-3 pieces, and then it would have been impossible to hold the ligament together. That was also one of the reasons why screw fixation met with a lot of failure. So we are basically cleaning the crater now. It's reasonably, looks reasonable, nice and clear. So we have to be absolutely happy with any encroaching fibrocartilage which might interfere, because if you have some fibrocartilage in between the two bony pieces, the union may not be adequate, and we will be left. So basically, if you see here, now you see here, it's basically more of a few fragments and not a single fragment here. You see, yeah, this basically are two fragments. There are multiple, actually more often it's basically a multiple fragments which are held together by a small cartilage on the top. So we have to be absolutely gentle and not do any harm. So once we continue clearing the debris and the crater, now it looks a lot clearer, and probably it's a happy place for the fragment to go in and sit. So after having cleared, now we are trying to put our determine the position where the pins go in, because we would be drilling from outside the tibia to inside. Basically, we would have 2 points. This is the first point. This is more on the lateral side at the junction of uh, the attachment of the fragment and the normal cartilage. So this is basically the crater, and this is the cartilage. So we choose a position junction. This is on the lateral side. This is the junction where we have a good bone purchase. This is the first pin which is going from outside to in. And now we would require a second one. Second one, I would prefer slightly on the medial side, so we have a good, the entire thing sits properly. This is more on the medial side. This is the cartilage, intact cartilage, hypocartilage, and this is the crater. So we choose a position in between, just at the junction. We have to be careful in determining the position so that the sutures do not come in between the bony fragment and the base. So the position has to be absolutely vital, because what happens, you get a tangled lot of sutures in between the bones and the crater which is sitting. So that invariably will result in non-union and failure. So this is the second drill which is coming. So basically we have two places. This is the one, the medial one, and the lateral one, fairly apart, and not actually sitting on the base on the crater, so it's outside. So this fragment would be sitting here, and with the help of two sutures we will try to fix the fragment in its place. So basically we have drilled the suture, so the zig comes off. Now the nice and fine fragment, we try to put the fragment back in its place with the help of a hook that sits there. Now, yeah, we see, check the position, it's entirely sitting comfortably here with good alignment, and we can see a fairly good native ACL. So we'll say take a couple of suture loops. The first one has already been taken. This is the first, where we take a loop surrounding the neck of this is the fragment and this is the attachment. So the first loop goes around the neck of the ACL. Few surgeons who just want to put a single loop around the ACL, because probably it's easier to do that way. But the problem with the single loop is, once we try to fix in a single loop, the other side slightly comes off. So the seating and the fixation is not very rigid. So if the seating and the fixation is not rigid, that would actually hamper the early movement and rehabilitation, and that will result more of in the stiffness of the knee. So my theory is, if we are going in for an operation, I want to do it in the best possible way. Trying to take in the second loop. The second loop is it's slightly more difficult because we have to take it in a different plane, making sure they are not in the same tissue plane. Otherwise, the entire ligament might rip off. So we have gone around the neck of the ligament, the second loop. So now we'll be putting in the second rope. So this is the fixation, where we can see two loops around the neck, one loop on the medial side, the other loop on the lateral side, and the final fragment sitting in nice and firm. The most important thing where we need to be actually careful that the number one, that there is no suture in between the fragment and the crater sitting in, and secondly, the loops should crisscross each other. So I'm showing you that in a moment. So nice and firm, trying to put in the tension so that the ligament is firm. Now here you can see that the two loops are trying to crisscross. That gives a very good stability and reduces the chances of failure. So trying to tension it properly so that the entire fragment is sitting in its place. This is basically what I'm saying is the crisscross. The one loop going here, the other loop is going here. So actually there you have a very tight structure sitting in. So this is how the thing finally looks. After I'm happy with the fixation, I generally tend to have a final look with the help of a hook that it's nice and firm. So here you see the fragment sitting nicely and there's nothing showing from here. So it's nice in position. So this is basically the post-op X-rays. This is basically suture disc. So what we have done is basically we had drilled a hole, couple of holes from outside here to inside, put in a loop down there, bring out the thread, and this is the suture disc. Over the suture disc, we have tied the knots out here. So if you see the X-rays, the fragment is no longer here. It's nicely sitting in its position. So the advantage of putting in a suture loop is it doesn't require a second surgery for removal. Secondly, it's a very rigid fixation. And after initial 4 or 5 days, when the pain, swelling, and the inflammation reduces, you can straight away start the rehab, movement strengthening, and early return to pre-injury levels. So this is the orthoscopic picture, and what I emphasize is basically this loop, using a couple of loops and crisscrossing each other. That's probably the best fixation we can have. Okay, next let us shift our focus to the second structure, which is the meniscus. Meniscus injury is more common in case of athletes or long distance runners. To start off with, we all know there are two meniscus. The medial one is the U-shaped and the lateral the S-shaped. The most common structure meniscus which are injured are the medial meniscus and the posterior horn, because the medial meniscus is the more mobile one and the posterior horn is also at risk of injury more. So how does a meniscus get injured? So it's basically when the foot is planted and the femur is internally rotated, the valgus force, when applied to the flexed knees, they cause a stress on the medial ligament and resulting in a tear. In active young, the most of the sports person, there is a traumatic longitudinal and vertical tear. Now, if you look at the vascularity of the meniscus, the peripheral 10 to 30% of the meniscus is very vascular. And in young individuals, sports or athletes, we should take all we should try and preserve as far as practical, because as we know, once we take off the meniscus, the buffer between the femur and the tibia goes away. So chances of early degeneration and early wear and tear and arthritis is there. So the current trend is try to preserve meniscus as far as practicable, particularly if it's in the peripheral vascular zone of 10 to 30%. The third is the medial collateral ligament injury. The MCL, as we know, is a prime static stabilizer of the medial side of the knee joint, and it's important for providing support against the valgus stress. Now, if we divide the grades of injury, we have 1, 2, and 3. Grade 1 and grade 2 injuries are quite innocuous, and they most of the time do well on conservative management. Grade 3 injuries are slightly dicey because they are more severe. An isolated grade 3 injury in a sedentary individual may not require an operative intervention. But in a sports individual, I would tend to be a little bit careful and try to go for an operative as far as possible. Secondly, what happens in sports person, more often a grade 3 injuries are associated with other ligaments in about 70 to 80% of cases. So more likely they end up being operated. This is a 35-year-old lady who has come in with a, basically she had a sudden twist of the knee. We see the MRI. Okay, this is where we see the ACL is not clear, suggestive of a tear. The second, the PCL is intact. The medial meniscus we see it's not homogeneous, and it's most likely a sort of tear, a large tear of the medial meniscus. And the MCL, where we see that there's a discontinuity in the femoral attachment here and a lot of edema. This is suggestive of a full sort of avulsion tear of the medial collateral ligament from the femoral attachment. So again, this basically this is a slightly different one. The other one which you shown was a ACL avulsion. This would be an ACL complete ACL tear where we go for a reconstruction of the ligaments. Now, regarding reconstruction, we have a lot of issues. I mean, lot of debates on which ligament which we use. We have the semi-T, we have the quadriceps, we have the bone patellofemoral tendons. So this is the these are the portion, the remnants of the ACL. This is the femoral attachment which has been shaved and cleared off, and these are the few of the remnants of the ACL. So trying to clear it off properly. It's very essential that we clear off the footprints, because we need to actually visualize the perfect point of attachment. Otherwise, if the anatomical point of attachment are altered, the function, the dynamics of the ligament changes. So the knee do not get back its original mobility. So this is more of, I'm coming towards the tibial footprint. So here we have to be actually very careful, because it's very close to the posterior horn of the meniscus. So we have to be very careful while shaving off the remnant, so that we don't do harm to the posterior horn. So this is basically a more of the remnant which I'm trying to shave it off. Okay, now this is basically the medial meniscus. So once we went and with a hook, we found that the entire medial meniscus was out of its place. So we had to bring it back to its place, and it was quite mobile and not very stable. So that if you leave that in place, more often once we start the rehab of the knee, it will be unstable and result in locking of the knee. So we need to fix this. So this is the first suture anchor which is going in. I mean, the fixation has to be very perfect, and we have to go deep posterior. So trying to find a suitable position. This is the first suture anchor going in. Yeah, and then now here you can see you're trying to bring back the meniscus to its original place, and thereafter we need a second one as well. So this is the thread going in. Yeah, so now you see the medial meniscus is pulled to its place. These are basically knotted, pre-knotted sutures, sort of not less sutures rather. So cut the sutures and you don't have an actually knot out there, so that won't interfere. Because what happens with when we use a manual knot, because previously what we used to do is we used to drill hole, put in a knot in the meniscus and come out. The disadvantage with that is you ended up having a knot in the meniscus, which in the long term used to hamper the knee rehab. So but with the new devices and guns, so we can actually have this knotless fixation of the meniscus. So basically checking whether the knee is stable, and just I find there are a few remnants here and there which will be shaven off in due time. So now it looks firmly in place, nice and good. The root and the posterior portion is also stable. This is basically the lateral one. Looks quite okay. So now having secured the meniscus, we now go to fix the ACL. So this is the femoral footprint. We are prepared carefully. So as I've told you earlier, it is very essential to see the anatomic position where we are going to drill and put in the suture and the graft. So mostly I do the graft, I take a graft from the semi-T because it is in fact uh, it has a less donor side mobility compared to the bone patellar tendon graft. Because in bone patellar tendon graft, what happens is we take a part of the patella, so it results in a lot of anterior knee pain and morbidity of the donor side. This is basically the first drill going in from outside to in, drilling into the femur. That is where we put the sutures and the graft goes in. This is the fixation point from the attachment point of femur of the ACL. This is in fact the left knee, so you can see the femoral attachment on the left side. So the drill going in of the appropriate size, the width of the drill depends on the graft. So basically, as we see, once after drilling, there is a lot of debris inside the knee. So I tend to basically shave it off and clear it off, because if you keep them a lot, it results in inflammation, swelling, and synovitis. This is the suture going in, the suture which should be carrying the graft inside. We pull it from outside the femur on the lateral side of the femur. So this is the footprint of on the tibia. So here we put the zig at the position where the tibial attachment would be, and again we drill from outside in. This is the drill coming up for the tibial attachment. So we need slightly to be careful while drilling in, otherwise it goes on and goes to hit the articular surface of the tibia, causing damage. So once we have drilled in the tibial hole, now we would prepare the tunnel for putting in the graft. So now you see the wider tunnel coming in. So this comes off. Now as just holding it properly to as the larger drill comes in. Now you find a fair amount of debris, fibrocartilage, gently shave it off to make it clear and reduce the chances of post-op inflammation. So again, the cleaning takes a lot of time and a lot of patience, unfortunately. But this is the one which creates that subtle difference of going back to previous pre-injury level earlier. So it's fairly clean now, and now it's time to be taking the graft. The prepared graft. The graft has been prepared earlier. It's put outside. So shortly you'll see the graft. Yeah, this is basically the suture which is pulling in the graft. This is the femur side, we're pulling in from the femur side outside. This is the graft going in. This is the semitendinosus graft. This is the femur. This is down here somewhere, it's the tibia. So this is the tunnel of the femur. Now we need to fix the graft to the tibia. So I'll be using a Milagro screw. So need to put in a wire out there. So the screw, the nice and fine, the screw goes in. This is, you see the screw. It's gently screwed inside so that the graft is fixed to the bone, and in the longer term it gets incorporated and behaves like a native ACL. So once we put in the femoral screw, we do a sort of cycling or tensioning of the graft inside the knee by cycling the knee around 15 to 20 cycles. After that, we tension the graft and put in a tibial screw from outside. So once the two screws are put in, we recheck with the help of a probe whether the graft is sitting well, and then finally it's time. So this is the post-op. It's slightly more than 3 months. This flexion is comparable to the normal one. The extension, there is a slight amount of lag of around 10 degree because of the quadriceps stiffness, and you can see the walking is fairly well. So the most challenging in this part, the ACL goes off well, heals well, is fine. But the most challenging part is the how the medial meniscus behaves, because more often at times we try to fix it up, but it doesn't stay. But I believe in young sports individual, we should, in case of such a huge meniscus injury, we would try to always preserve and fix the meniscus. Now the third, basically the third is the PCL injury. So in cases of acute isolated PCL injury in grade 2 injuries where the posterior tibial translation is between 8 and 12 mm, we can do away with the non-operative management. But those, and also those grade 3 injuries who are non-athletes, I mean the sedentary individuals who are not symptomatic and participate in low demand activity, they can do well with non-operative management. But in the acute PCL injuries where the tibial translation is more than 12 mm or associated with repairable meniscus tears, or there's an associated of knee dislocation or bony avulsion, or there is a chronic PCL injury with posterior tibial translation of more than 8 mm. Symptomatic PCL injuries in athletes should always go for a PCL repair. So this is the third case. This was in fact a very bad injury. So this individual, as we see in the CT scan, there's a bony avulsion of the PCL. This was in one knee. He had a bony avulsion of PCL, which was fixed from posterior aspect. We had fixed it with a suture anchor. The bony avulsion along with the ligament was fixed with a suture anchor. So this is the MRI where we see this. The PCL is ripped off from the posterior surface of the tibia. So this is the post-op. This is the suture anchor, and this is the avals portion which is sitting nicely here. And this is the left knee, the other knee. Here in the MRI, we can see the ACL is not visible. So there's a discontinuity there, the ACL. There's a PCL tear as well. So the PCL is hazy and we do not see a complete PCL. And there's a femoral avulsion of the femoral attachment of the MCL. So this individual has in fact 3 injuries. One is the PCL, one is the ACL. Sorry, this is the ACL, the PCL, and there's a avulsion of the femoral attachment of the MCL. So this has to be done in 2 stages. In the first stage, we did. In the first stage, we planned for doing the MCL and the PCL. Now, regarding the time of surgery, well, there's no general consensus regarding the best suited time frame for surgery. Previously, there were most of the surgeons were of an opinion that we would wait for around 6 weeks for the knee to get cool, for the swelling to subside, and then start operating. But in case of multi-ligament injuries where 2 or more ligaments are affected, if we wait for that time frame of time, it results in stiffness of the knee. So now most surgeons advocate the role of surgery early, around say 3 weeks of time, because that allows us early rehab. So I would rather wait for 5 to 7 days time for the knee, for the swelling and the inflammation to subside, and then start off with the surgery. In this case, we planned for a 2-stage surgery. The first stage, as I told you early, we did fixation of the PCL along with fixation of the MCL. Here you can see the suture anchor, which is fixing the femoral attachment of the PCL. Now he is waiting for the next surgery, that is the reconstruction of the ACL. Now, having discussed the various ligament injuries, now it's time for rehab. The first question which the athlete or the sports person would ask you: when can I get back to surgery? When can I get back to active sports? When can I get back to normal life? Well, that depends. There's a no thumb rule for all individual or for all surgeries or for all ligament repair. But most of the individuals who had more than one ligament injury generally gets back to their pre-injury level around 8 to 12 months time. If it's lucky, if it's a single ligament, sometimes they are lucky to go back to the field around 6 months. Now, what are the criteria where we decide when it's time to get back to the field? Number 1, absence of pain and effusion. knee range of motion comparable to the contralateral limb, a negative Flatchman or a pivot test, and successful performance of the hop test, around 85% to 90% of the performance of the contralateral limb. So now, having done the surgery and everything, it's over to the physiotherapist for taking the rehab and further. Thank you.
Thank you, sir. I request participant, please, you can ask question. You can put in the chat box. Rishi, please search any question in Facebook page.
On either side of the joints helps to stabilize the knee in their respective positions. So all these ligaments.
There is no question in Facebook, and some questions are coming in this chat. That sir, what is unhappy triad? Is the management same as you told about other injuries? Son, one participant, the name is Susmita Sharma, has asked, sir, what is unhappy triad? Is the management same as you told about other injuries?
I mean, what sort of unhappy triad? I mean, there's a lot of
sir. So, sir, she is asking, sir, the management same as you told about other injuries.
Rishi's question is not cleared enough.
I mean, not clear. Yeah, what does she actually mean? Yes. I mean, the unhappy triad is basically what you have is basically what I told you. There's a damage to the, I think, the ACL, the medial meniscus, and the medial collateral ligament.
Okay, sir. Sir, another question is what all the criteria?
Yeah, so sorry, just one moment. Yeah, because the first case which I showed you, she had a ACL tear, a medial meniscus tear, and the medial collateral ligament tear. So it had, since the as I told you, the medial collateral ligament grade 1 and grade 2, we may leave it, but if it's a grade 3 and associated with other, say, ligament injuries, we need to fix it off. That is what I had done.
Sir, the another question is what all are the criteria for going for a surgery? To which extent it can be managed conservatively?
I mean, that depends what type of ligament tear or ligament injury it is.
Okay.
I mean,
it depends upon the grades. Yeah.
So, a gentle sprain, do well. A very small partial tear, do well with rehab. But if there's more than that, say complete tear, it definitely requires a proper surgery and rehab. Partial tear, it's a gray area, so it will vary from individual to individual depending what portion of the ACL is torn.
Sir, another question is why the loops of the suture should be crisscross?
Yeah, that's because basically, if you see this is a ligament, one loop comes this way. So if you're trying to pull this loop here, this portion actually pulls out. So if you have two loops from two sides sitting in, so it will be a stable fixation. So one side, if you pull it, the other side comes off. So if you're pulling from two sides, the whole fragment sits in properly. So that is why you need a crisscross.
Yes, sir, that's fine. Hello, Kaushik sir.
Yes,
Yeah,
yes.
hello. So now basically I will ask you some questions. Okay. So now starting with the same. Oh, sorry.
Sir, another question.
Yeah,
Sir,
yeah, yeah.
another question is also coming, sir. Sir, can we not give them circular loops?
Yeah, this is basically a circular loop. I'm just trying to explain it.
Okay.
This suppose it's difficult to explain. Just one moment if I find something. Okay. Yeah, this is a bit crude one trying to explain. So if I say this is an ACL tear, so it's sitting in here. The both are circular. Each of the loop is circular. But what happens is if we do a circular surrounding the neck. So if we pull from one side, the other side might come off. So if we are pulling from two sides, both sides will sit in position. Both are circular, but it needs to be pulled in from two sides. If you pull in from one side, the other side will come out. So that will be an unstable fixation.
Yes, sir.
Yeah. Anything more? Yeah, the one thing I was going to ask again about the unhappy triad. So regarding the rehab, what sort of precautions would you take while starting the rehab in case of an unhappy triad? That is where when we have fixed the MCL, the ACL, and the medial meniscus.
Sir, participant can't talk actually, sir. They are
So
muted.
okay, so I can ask you.
Sir, I'm not getting. Sir, could you please ask me another?
Okay, no. Basically, just a very simple one. What I am asking is, as far as the medial meniscus repair is concerned,
Yes.
so when do you actually, I mean, in your practice, when do you actually try bearing weight for individuals?
Bearing weight.
Sir,
Weight bearing,
sir,
yeah.
sir, first of all, so, sir, to achieve the full weight bearing, continue to increase the first the range of motion, sir. So
Yeah.
then increase single leg stability, then some strengthen exercise for the core, hip, knee, and ankles. Because sir, exercises such as waist shifting or a single leg stances and partial mode squats are typically performed for increase the range of motion or for complete react. Sir, it depends upon the vary to patients also.
Yeah, because for me, in a medial
Yeah.
meniscus, I tend to give weight bearing after say partial weight bearing in 3 or 4 weeks, and then start a full weight bearing after say 5 to 6 weeks. Because
Yeah.
I am very cautious about the meniscus repair, and for an ACL, it's fine. The chances of failure are very relatively low, but meniscus, I am very worried.
Yes, sir. Yes, sir.
Yeah.
Sir, in meniscus injury, sir, the players will be returned in 3 to 5 months or more than
I, I,
5 months.
I
Because sir,
think I think
you last told that it takes eight
No,
to
that
ten
is
months
Yeah, 8 to 10 months is the maximum. Basically, if there is a
maximum.
multi-ligament injury,
Yeah.
it
Okay.
sometimes takes 8 to 12 months. Because if there's an isolated ACL, probably 6 months would be fine. But in where there's a more than one ligament, it might take more. I mean, somebody may be fortunate, maybe doing a good rehab and everything. So 6 months is probably the minimum time, and 8 and 12 is stretching a bit. I know it's stretching a bit,
Yeah.
but it's always better to be on the
Yes,
safer
sir.
side.
Yes, sir. Sir, some questions are there, sir. Sir, what I suggest, full weight bearing will be 6 to 7 weeks.
Yeah, yeah. That's what we were discussing regarding the
Okay.
meniscus.
Okay. Okay, sir. Thank you.
Okay.
Thank you, sir.
Okay, thank you so much for giving me this
Thank,
opportunity. So hope we would come back together and share a few more experiences. So
and
maybe
thanks, sir. We learned lots of things, surgical things from you, sir. So it will be a very good session, sir, right now, sir. So thank you, sir.
thank you so
Thank
much.
you, Dr. Rishi. Alupi ma'am, up to you.
Yes, sir. Thank you so much, Avishek sir. Thank you so much, Rishiraj sir, for your presence. Sir, it was actually wonderful session. And thank you so much, all participants. My big thanks extend towards our IAP President, Dr. Jha sir, IAP Treasurer, Dr. Ruchi ma'am, for providing a platform. Thank you so much, West Bengal team. Thank you so much. Before end this webinar, I again request to all participants, please subscribe our IAP YouTube channel and Facebook page for watching more and more webinars. Thank you so much. Thanks a lot. Good night.
Thank you.
Thank you, ma'am.